Welcome to this explainer. Look, today we're putting on our medical detective hats. We're going to uncover how doctors truly evaluate your cardiovascular risk, and in doing so, we're shifting the focus way away from the anxiety of a single cholesterol test result. Because, as we're going to discover together, that one number, it's really only a tiny fraction of the real story when it comes to your overall heart health.
Okay, let's quickly run through our roadmap for today. We'll be looking at 1. Beyond the cholesterol number. 2. Primary and secondary prevention. 3. Diabetes and kidney disease. 4. The power of lifestyle. 5. Hidden risks and blind spots. And finally, 6. Genetics and secondary causes. Let's get right into it.
All right, starting off with Section 1, Beyond the Number. So we have to bust a huge myth right out of the gate here. Does a high cholesterol number automatically mean you need medicine? It's a super common question, but the answer is a resounding no. Think about it for a second. High cholesterol itself doesn't actually cause symptoms, right? You can't feel it. And because of that, treatment is based entirely on your overall cardiovascular risk profile, not just reacting to one isolated number on a lab report. High cholesterol is just one clue at the crime scene, definitely not the whole case.
So how do doctors actually figure out that overall risk? Well, they use tools like QRISK-3. This is the NICE recommended clinical calculator for adults aged 25 to 84. And it's actually fascinating because it doesn't just look at your cholesterol in a vacuum. Instead, it acts as this comprehensive algorithm. It combines your age, sex, blood pressure, BMI, and your specific medical history to calculate your true cardiovascular risk before any disease actually occurs. It's essentially a predictive model for your future health.
Now, here's the magic number you really need to remember. 10%. If the QRISK-3 tool calculates your 10-year risk of a heart attack or stroke at 10% or higher, well, that's when doctors generally recommend discussing atorvastatin 20 milligrams as a primary prevention measure. But, it's a shared decision. What's incredibly interesting here is the 25-in-1 number needed to treat. Basically, this means roughly 25 people need to take the medication for one person to successfully avoid a cardiovascular event. It really kind of puts the statistical reality of preventative medicine into perspective, doesn't it?
Moving right along to Section 2, Primary and Secondary Prevention.
But what if your risk isn't just a possibility in the future? What if you already have established cardiovascular disease? This reveals two completely distinct pathways that doctors use. Primary prevention is for when the disease hasn't happened yet, relying on that QRISK-3 tool we just talked about and a lower statin dose, usually 20 milligrams. But secondary prevention is for folks with prior strokes or angina. Here, doctors completely bypass the QRISK-3 tool. The risk is already confirmed, so they go straight for a high-intensity 80 milligram dose to aggressively protect the heart. It's literally the difference between installing a smoke detector and putting out an active fire.
Up next, Section 3, Diabetes and Kidney Disease.
Let's see how special medical conditions can totally alter those standard guidelines, because standard risk tools absolutely aren't a one-size-fits-all deal. Take chronic kidney disease, or CKD. Doctors will often just bypass QRISK-3 calculations altogether and offer atorvastatin 20 milligrams immediately. Why? Because the kidneys and the cardiovascular system are so deeply linked that standard tools actually underestimate the danger. For type 2 diabetes, doctors still use QRISK-3, but the condition substantially pushes the score way up. And for type 1 diabetes, statins are often recommended regardless of the score, especially for those over 40, folks who have been diabetic for more than 10 years, or those with kidney complications.
Which brings us to Section 4, the power of lifestyle.
So, what happens if your QRISK-3 score is comfortably under that 10% mark? Well, your first-line prescription isn't a pill at all. It's a fundamental change in your daily habits. And these aren't just polite, throwaway suggestions from your doctor. Swap in saturated fats like butter for olive oil, hitting 150 minutes of weekly moderate activity, and staying under 14 units of alcohol a week are incredibly powerful evidence-based tools. And above all, quitting smoking through services like the NHS offers a massive risk reduction that literally rivals many prescription medications. It's all about building a physiological fortress against heart disease.
And honestly, what is so incredibly encouraging to discover is that you do not need to endure extreme, punishing diets to see clinical results. Simply reducing your body weight by a modest 5 to 10% yields measurable, tangible benefits to your cholesterol levels. This matters immensely because it shifts the goalposts from these overwhelming transformations to sustainable, realistic changes.
It means a few small, consistent habits can actively rewrite your long-term cardiovascular health. No need to chase impossible standards.
Section 5. Hidden risks and blind spots.
Even the very best medical detectives know their tools aren't perfect, and the QRIS-3 calculator is no exception. In fact, what's missing from standard calculators is crucial. If a patient has an unlisted condition like psoriatic arthritis, their chronic systemic inflammation is actively raising their cardiovascular risk, but the algorithm, it's completely blind to it. Similarly, broad psychotropic medications, like certain antidepressants, can cause unseen metabolic changes. So a calculated score might look reassuringly low, while the true underlying risk is dangerously high. This is exactly where a doctor's human judgment has to step in and override the math.
And our final section, Section 6, Genetics and Secondary Causes.
Finally, we have to look at the true outliers. A total cholesterol reading above 7.5 is a massive red flag. A number this high prompts a doctor to look beyond lifestyle entirely. They're going to suspect familial hypercholesterolemia, or FH. This isn't about eating too many burgers or skipping the gym. It's a purely inherited genetic condition where the body's recycling system for cholesterol is essentially broken from birth. It requires an immediate referral to a specialist clinic because honestly, no amount of diet or exercise alone is going to fix a genetic misfire like this.
To figure this out, doctors use a fascinating tool called the Simon-Broom criteria to categorize this genetic risk into either definite or possible. Definite FH involves high cholesterol plus physical signs like tendon xanthomata, which are actual cholesterol deposits under the skin, or a confirmed genetic mutation. Possible FH pairs high cholesterol with a family history of premature heart attacks. Catching this early is absolutely vital because the cardiovascular damage from lifelong elevated LDL starts decades earlier in these patients. We're talking about severe, hidden risk accumulating in a person's 20s or 30s.
But wait, before starting any lifelong cholesterol treatment, guidelines insist on playing detective one last time to rule out secondary causes. And one of the most common, yet surprising culprits is the thyroid. An underactive thyroid or hypothyroidism literally slows down your body's metabolic ability to clear LDL cholesterol from your blood. It acts as a physiological roadblock, raising your cholesterol entirely independently of your diet, weight, or genetics.
So think about the implications here for a second. What if simply treating a slow thyroid fixes your cholesterol profile entirely, without you ever needing a statin? It absolutely happens. And it proves perfectly why cholesterol is never just a single isolated number on a page. It's a complex, interconnected puzzle that needs complete clinical context. As we wrap up this explainer, I'll leave you with this thought. What other hidden clues might be lurking in your own health data, just waiting for the right medical detective to piece them together?